Happy New Year. I hope it hasn't been too painful getting back to it. We are delighted to be back with a new episode of Soundbites, the first of 2022, because we've got Dr. Dane Rowley with us today, talking about something that I think probably a lot of us have experienced that work with clients or patients with traumatic brain injury. Without any further ado, we'll just get cracking. And today we're talking about something that's so interesting and really important, actually, in the context, not just the type of work that I do, but for everybody that deals with clients who have sustained brain injury. And we're talking about engagement and insight and that sort of stuff. So I mean, it is something that we are all too familiar with, and I just thought it would be a good idea to kind of start off, if you could explain a little bit to us about kind of the impact of poor engagement.
Yeah, okay. So I suppose there's two sides to that coin, isn't there? There's the impact that poor engagement in rehab has on the person's health outcomes from a clinical perspective. And then, more from your point of view, Emma, there's the impact that it has on the litigation process. So if we think about the health stuff first, if somebody, for whatever reason, isn't able to engage in a comprehensive package of support that's been provided to them to help them rehabilitate from their injuries, it stands to reason, doesn't it, that their progress and their recovery is likely to be poorer than it would have been if they'd been able to fully engage. So it's about quality of life, it's about restoration of function, it's about mental health, it's about well-being, it's all about, it's a really kind of holistic issue that can affect all areas of someone's health after an injury. From a litigation perspective, it can potentially massively affect litigation, can't it? It can, the poor engagement often comes across as self-destructive, and it can be misconstrued as deliberately sabotaging, as purposeful, and that can really impact the ability of litigators to get the package that a person really needs in order to kind of help them make progress. I'm sure we've all seen it being used to unfairly justify withdrawal of support, withdrawal of rehabilitation provision, and often that's when arguments win out that it's purposeful or deliberate and intentional, and that can be in the context of a kind of lack of understanding, really, of the kind of neurobehavioral causes of that disengagement.
Yeah, and I suppose the only thing I'd have to add, I suppose, from a litigation perspective, is that it's always best in these types of cases to have something set up and trialed, and to be able to show that it works. And of course, it can be a huge challenge for treating clinicians, case managers, and trying to, justify those cases where you're saying, look, this isn't a deliberate kind of attempt to thwart input, and insight feeds into this quite heavily, doesn't it? So we'll come back. I'm jumping ahead, but we'll come back to that. I wanted to just discuss a little bit about whether there are any kind of predictors or kind of typical characteristics that expose themselves as patterns in terms of poor engagement.
Yeah, I mean, I think there are patterns and generalities. All cases are individual, aren't there? But there tends to be, I mean, both the research shows, and I think a lot of our own just clinical experiences tend to show that people who are more at risk of poorer engagement, it tends to be younger men. It tends to be younger men from quite socially deprived backgrounds. It tends to be younger men from socially deprived backgrounds with psychiatric histories, with current comorbid kind of psychological mental health difficulties. If somebody is hopeless about their potential for recovery and rehab and to regain the life that they enjoyed previously, that's a massive predictor of poor engagement as well, because if you don't believe things can get better, why would you put all your time and energy into trying to get better? Mistrust of health professionals, that's come to the fore in the last few years with COVID and COVID vaccines, hasn't it? And this is another way in which people disengage. And then the big one that we all know loads about is dysexecutive syndrome, and that can be for a few different routes. It could be, so I like to see it in kind of three ways, really. So dysexecutive syndrome might cause poor insight, poor monitoring of what someone's abilities are. If you believe you're really good at something, why on earth would you engage in rehab because you've not got a problem? The other one is poor self-regulation abilities. If you have a really difficult time foregoing reward now in order for a bigger payoff later, you're going to have a hard time investing in the hard work of rehab in order to get that good outcome if you're impulsive and you make that decision based on what feels good there and then. And the other thing that dysexecutive syndrome can do in some cases is cause what we call a disorder of drive, or adynamia, I think is the neurological term. And that's that general kind of presentation of lack of spontaneity, lack of ability to get up and go. And that can mean that people have the best of intentions, but day to day, they're just incapable of doing that, or they find it very, very difficult to do that hard work. So there's loads of brain injury related reasons, as well as more kind of demographic factors that can cause it.
It's so interesting, Dane, and I wonder, and I'm asking this, I'm just picking up on a point that you mentioned there about kind of mistrust, which I find really interesting. And I wonder whether it's your experience that issue has kind of been exacerbated in the context of the pandemic.
I don't know whether it's exacerbated it or exposed it.
Right.
I don't. It's suddenly this huge political occurrence, isn't it? That means that these fault lines have almost been shown up and exposed. I wonder if it's been bubbling under the surface for many years, and that this is, a really concrete thing that's demonstrating it, the disagreements in society.
Yeah, and of course being plastered all over the media and social media and being everywhere all the time.
Yeah, exactly.
It's helpful.
Everybody has a view on it, don't they?
Yeah. Absolutely. I'm going to ask you now the $1 million question, which is basically how do we deal with this issue of poor engagement, from a practical point of view, and to what extent is a multidisciplinary approach required?
We need an MDT approach in these cases, don't we? All of the evidence says that working in a unidisciplinary way with someone with multiple problems across all of these different domains after TBI, when they're dysexecutive and not engaging, it's not effective. We need that coherent, intensive approach. There's some basic ways that we all in our everyday practice try to deal with this issue, and that's the kind of the basic principles of person-centered working, isn't it, and goal setting. And the idea behind that is if a person is working on something that is personally meaningful to them, they are more likely to engage in it. And I suppose that, you can understand in that context how person-centered working and goal setting are really, really important as prerequisites. But they don't always work. In dysexecutive syndrome, for example, someone, as we've talked about, can have the best of intentions, but just be unable to put it into practice in action in day-to-day life. So it's not a panacea for these problems. It's not something that you can just say, if we work in a person-centered way, then engagement problems will go away, because I don't think that that's the case. I think they can be a lot more tricky than that in these complex cases. It's
maybe wrong of me actually to have split the session into kind of engagement and insight, because I know that the two are kind of linked in every way, oftentimes, but it, I think maybe it's just easier to compartmentalize it that way. So in terms of insight, I'm kind of setting you up for my next question here, but I wanted you just to explain a wee bit about kind of the kind of traditional approaches to dealing with issues regarding insight.
Yeah, okay. So what I see as the traditional approaches are the BERT model, the neurobehavioral model of understanding poor insight as due to a faulty monitoring mechanism in the brain. So the idea being this person is no longer able to look at themselves and judge appropriately their strengths and weaknesses. The sensible thing to do in response to that, and the neurobehavioral model does very well, is to provide that feedback externally. So that might be videoing a client as they perform a task so that they can look back at it and see themselves in a different light. It might involve me sitting in a clinic and giving verbal feedback about someone's aggressive behavior or something like that to them. It might involve getting them to predict how well they think they'll do in a task, and then actually review how well they actually did afterwards. So there's all those kind of traditional ways. And sometimes they're good and sometimes they're useful, but they do take a very kind of expert position. And that expert position is, I, the doctor, am more knowledgeable about your abilities than you, and I'm going to help you to understand yourself as in the way that I do. And in these really complex cases, I feel that assumption of that model can just create an enormous amount of conflict between clinician and service user. So I think that if that's working, great, it's working. But if it's not, we need to work in an evidence-based way. And if it's not working, we need to adapt our approach, I think, if that makes sense.
Yeah, it absolutely does, Dane. And I suppose there must be more kind of maybe complex and more kind of difficult to reach clients where that approach doesn't make sense. And so
yeah.
What are the alternatives for that? I'm asking practical tips. Dane, I'm really drilling you, I'm sorry.
Yeah, no, not at all. No, and this is the kind of stuff that I'm really interested in. I think that the answer to some of these cases lies in the depths of old family therapy and systemic therapy books. And these kind of approaches come from a different kind of background to neuropsychology, really. They've developed very separately. But what some of these approaches do is they take a completely non-expert view and a non-expert position on the nature of the problem. I think an analogy is really good here. If you were down the pub and you'd got a few of your mates around the table and you were arguing over politics, Brexit, whatever it might be, if your job was to try and increase agreement around that table about the issues, you would never in a million years approach it as an expert. I don't think you'd go in there and say, actually, this is the truth of the matter. I think you'd go in there really diplomatically and carefully, and I think you would be really curious about all of the different ideas around that table and what it is about that person's history and life story that means that they've developed that view. And you'd probably try, if you were trying to get some agreement as a diplomat or a negotiator, I think you'd probably try to help people around that table find areas that they actually do agree on, if that makes sense.
Yeah.
And be curious and collaborate and take yourself out of that expert position. And I think that sometimes when really difficult to reach clients who are mistrustful, they've got a long psychiatric history, they're dysexecutive, if they start to see you genuinely alongside them and trying to understand their perspective on an issue and not telling them that the evidence doesn't suggest that,
yeah,
then often you find that they might start to gently in their own time, very, very slowly come over to a new way of seeing things, or at the very least, at least understand that other people around them have a different view and understand why. And sometimes it can just take that tension out of the discussions.
Yeah, and it must require quite a bit of kind of getting to know your client or patient quite well, doesn't it? I mean, you've got to know kind of their likes and dislikes and their views and a bit about their history. And I wonder how much family feed into this, how much family and friends can they play a part in that?
Yeah,
is that
absolutely.
something in your experience that's been important?
I personally, in my practice, I much prefer to have a round the table discussion with as many people as present as possible. And I think that feedback that happens organically and in that round the table discussion from family members is so much more powerful than the feedback that I could ever give, you know, as an expert with my doctor hat on.
Yeah.
So absolutely, I think as long as there's consent there and an understanding of what the forum's for, I think it's about bringing as many people to that discussion as possible, because the idea in systemic therapy is the more ideas are out there, the better a system can learn to take account of all of those ideas and change, if that makes sense.
Yeah, absolutely. It's such a complicated and interesting area. I wish we had longer to cover it, Dane, but you've done such a great job in the very short time that we have, and I thank you ever so much for coming along today and talking to us about this. It's super interesting. Dane's kindly agreed to put his contact details on the end slide of the recording, so if you go onto our website and find the recording, then his contact details will be on there. You can also have a stalk and get him on LinkedIn and that sort of thing as well. Not that I'm opening up your inbox to all sorts, Dane, but I'm very grateful to you. Thank you ever so much, and I hope that was as interesting for everybody else as it was for me. And we'll see you very soon again. Thank you. Bye.
Thank you. Bye-bye.